Hi everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you a really interesting discussion around data and the importance of data and how to make data valuable in healthcare. Today's guest is Mike Noshay. He's founder at Verinovum. Welcome, Mike.
Thanks so much for having me.
Yeah, so excited to have this discussion. And before we dive into, maybe we should call it dirty data. Do we dive into dirty or clean data? Anyway, whatever. Tell us a little bit about yourself and your work at Verinovum.
I'm a proud father of two-year-old twins, so life is busy at this point in my life.
I bet.
Beautiful wife at home, and very thankful for the last 8 years in this journey of trying to solve the dirty data conundrum that exists in healthcare.
Yeah.
My primary role is focusing on strategy and our marketing efforts and helping oversee some of our product development.
Awesome. So as you look at it, how are we looking at health data today? And how should we be thinking about it maybe differently than we have in the past?
Especially being here at HIMSS, it's really interesting to walk around the floor and see all these really amazing point solutions that are trying to solve for comorbid disease states or some sort of algorithmic intervention to better risk stratify the patient population. I think the challenge that we run into is those point solutions unto themselves don't provide the comprehensive picture. A really fascinating article came out from Google AI Research just 2 weeks ago that said the majority of AI creation is flawed. They did this retrospective analysis and came up with this term data cascades. It says most of the data that's being applied to support machine learning and artificial intelligence was done in a contrived sense. And so these next generation outcomes weren't using a quality data pipeline in support of driving the triple aim. So you got to go back to the foundation and say, hey, if we really want to achieve that outcome, what are the sources of input that we have available to us? What is the confidence interval and quality of that data available to make sure that we can actually achieve the outcome we want? Because if you don't have quality data, quality input, no matter what algorithm you put it into, you're going to have a flawed outcome.
Yeah. So you talked about it a little bit, but how usable is the data today? I mean, we're using it, right? I'm getting care based on that data, so it scares me if it's too flawed, right? But give me an idea, how usable is it? What is it used for? And what is it useful for? And maybe where is it? Maybe machine learning and AI, it's not good enough, or how do you look
I think context here is really king.
Yeah.
So when you're sitting in front of a doctor and they're trying to triage you, their expertise and their historical background and training should be able to give you the care that you want. Or if you end up having to go across multiple facilities and seek various types of treatment, the likelihood that the quality of the data across those facilities is being put together and a comprehensive picture of you is slim to none. When you experience that every single time you go to the doctor and you have to fill out a new form. That gets compounded even further when you're looking at advanced use cases for insurance providers or large hospital systems to look at their entire roster of patients. And they've got multiple or hundreds of streams of EHR clinical data coming into a single head. The order of magnitude, complication, and discrepancies in the quality of that data is untenable. And you really only have a couple of approaches to look at it. You can throw a mountain of data scientists at it, which isn't allowing them to do their work at the highest level of their licensure, or try to take a more fundamental technology approach. That's the way we look at it. And we bucket it into 3 different categories. 40%, relatively good data.
Okay.
Minor business rules can probably handle the outcomes. The next 40%, steeped in billions of transactions, we've been able to build algorithms to lift the quality without having to burden the source with the issues that happen.
Okay.
And the remaining 20 is a learning environment that helps us focus on the outcomes that a customer wants to achieve, remediate the areas as they exist, work with the sources if we have to, and then make sure that we're taking that learning approach to say, how can we make the first 2 buckets better over time?
Yeah, that's really interesting the way you divided it to understand the different types of data. That's a beautiful description. But I think it's also interesting to look at it and say, okay, well, great, now we have all this data, which I think is actually really exciting, because 10 years ago we didn't. Yeah. Well, we did, they were on paper records, they're unusable, right? But okay, we have this data. How do we turn that into action? Are there any examples you could think of, the people you're working with, organizations you're working with, that they're really using it to improve care?
I think the key to this is saying you don't want to be all things to all people. Any organization that wants to boil the ocean and make every piece of data they have available tenable for every outcome and every business decision is going to fail. You have to be hyper-targeted in the things you want to achieve. We work with customers that have said, hey, Mike and the Verinovum team, across our organization, we have 135 different use cases for clinical data. I say, great. let's dig in and figure out from your business owners what that really means. And after investigative research, you really find that it's more like 30. There's a lot of overlap across them, just slight terminology differences, and they typically resolve down to high-value comorbid disease states. Your diabetic patient population, your COPD population, and the underlying data elements that are needed to support those sorts of outcomes. When we think about prioritizing those 30, we then say, across your members or your patients, which of those are going to have the greatest financial return or improve the quality of life for the greatest patient population? You take those 30, you say these 5 are the most important, and you just start from the top. We like to say that the appropriate boundaries between a vendor solution, the data contributor, and the user is really important. It's not to say you can't solve for all 30, but if you start off saying, I'm going to do all right now, somebody's going to get angry, and you're not going to have a good long-term relationship.
Yeah, and then you have a failed project, and no one wants that.
Yeah.
So do you see them doing more clinical or more financial, or is it a mix? Or how do you see that kind of breaking out as you've worked on projects?
We have specifically focused on the clinical transactions, and this is steeped in my past experience. I was fortunate to be part of the original years of the health information exchange movement that came out of the ONC in the 11, 12, 13 timeframe, and we had our hands in a bunch of federal dollars to go out and solve the triple aim, get data from all the providers in the community, bring it together, and then make it ubiquitously available for patient care. What we found is that getting access to the data wasn't a problem, but the quality of the data was so poor that you couldn't actually use it for treatment intervention or advanced use cases. And so we said, that's all we're going to focus on. There are lots of institutions that focus on financial, whether that's claims or just payment methodologies. It's a lot of institutions that focus on case management intervention. But the middle tier, the actual metadata and the clinical content that happened when Sally went to the hospital and the outpatient facility and the specialist, nobody's reconciling all of that material. That's all we're going to do. Get data, clean data, curate and enrich it, and give it back so those that want to intervene can have something they have confidence in.
Yeah. I love the place you're working because it's a love-hate thing. I love it because it's never done. At least I don't think it's ever done, right? But then it's also challenging because it's not like, okay, I've implemented my EHR, I'm kind of done. Is that a challenge you see too? Is that like this work will never finish? There's always more to discover?
I think that's a good thing. That means that we're building new frontiers and figuring out the next thing that's going to solve patient problems. And I mentioned before 40-40-20. That 20% or some derivative thereof will always exist because there's new EHR upgrades that come out or a new standard that exists in the industry. Everybody right now says FHIR is going to solve everything. Problem is FHIR doesn't contemplate quality of the data that's being fed into it.
Yep.
And so we really believe that the leaders and the laggards in standards adoption don't have to be independent of each other. We can act as a unifying force to help both sides meet together to drive lasting outcomes.
Excellent. This has been a lot of fun. So where can people go to learn more about Verinovum?
We have an awesome marketing team, Verinovum.com. Hit us up on LinkedIn, Twitter. We'd love to connect in any way that you have interest.
Awesome. Thanks, Mike. And thanks, everyone, for watching. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com. Thanks, Mike.
Thank you.